Well, good morning, and our job's to add value to the start of today. And value is very important, as we'll explain to you over the next hour and a half. There are my disclosures. We're here because we believe that health is a human right. And if health is a human right, then access to the treatments that will deliver health is also a human right. And we're here to look at the innovation in cancer treatment because we're responding to a change in the pattern of disease in the world. This is the heat map of non-communicable disease. The darker the colour, the more important it is. And of these diseases, they're typical chronic diseases, asthma, heart failure, diabetes. It's important to remember that the biggest of all of them is cancer. Now, we have a world programme to deliver free or affordable drugs for malaria, TB and HIV to the world. But remember, cancer has an impact bigger than all of those three diagnoses put together, tripled. And we can't yet deliver those medicines. Now, to manage this big change, we need innovation and we need lots of it, which is why ESMO's here and why you've given up your time to come to the conference. And remember, we're called ESMO for a reason. We believe that medical oncology can transform outcomes in cancer. We point to our track record that at least half the life years saved in cancer over the last 40 or 50 years have come from what we do with better treatments. It's not to say that prevention and early diagnosis doesn't play its part, but we're here for a good reason. And when our specialty began back in the 1960s, we had only 5 drugs. And with each decade, we added a bit more innovation. But, you know, as we've understood what it is that drives cancer, those fundamental mechanisms in the cell, something remarkable has happened. Our innovation, our delivery, our exponential delivery of innovation has been remarkable. We think by the end of this year, we're going to have more than 200 cancer medicines in our formulary, with more to come. But that puts pressure on our drug budgets, because innovation is always expensive. And you'll see that our drug budget to keep pace with cancer medicine is inflating at around 12 to 14% a year. That's double the rate of the global drug budget. And what I ask people is, does your hospital, does your healthcare system have a promised increased spending in real terms next year of 12 to 14%? If it doesn't, you risk falling behind with innovation. Because the biggest global health challenge today, according to the WHO, is not new emergent infections like Zika, it's access to the treatment that we know already works. And it's not just a problem for poor nations, it's a problem for rich nations too. A diagnosis of cancer in America takes the life savings of 1 in 5 patients' family's wealth. That's the money the family put aside for weddings, for university fees, for retirement. And even in socialized Europe, our healthcare systems are buckling. The European Commission believes that perhaps only 2 of 28 European health systems are sustainable through the next 30 or 40 years. Now, look, the only health economics I really have to teach you is this. The only medicine that works is one that we can afford, and increasingly, we are worried that we can't afford the innovation you're going to read about today, because the median annual cost of a new cancer medicine launched in 2017 exceeded $150,000 with its ticket price. And that's 3 years average household income of an American family. For example, the checkpoint inhibitors that we're going to be hearing a lot about, I'm sure, are typically coming with a ticket price of more than $12,000 a month. And already this means in Europe that there are serious gaps in the availability of basic treatments for cancer. And these drugs don't just work in cancer too. You'll see, for example, in inflammatory bowel disease, that there's a direct correlation between the wealth of a nation and access to these medicines. It's driven by wealth and not by patient need. So the reality of cancer care now, according to the Wish Foundation, is very clear. Cancer care is not affordable for most patients, many payers, and nearly all governments. And it's a real and immediate issue across the world now. We have a problem. Just as we can see a new horizon for our specialty, we might fail not because we can't innovate, but because we can't afford to apply that innovation. The reality of today's meeting is you're going to be reading about lots of innovation coming out. But within 2 years, if we ask, of the 200 nations of the world, in how many will at least 7 out of 10 of those new advances be available? The answer is 2. US, Germany, and the UK. And at least half will be available in only 6. And that leaves 194 nations of the world without the majority of the innovation you're going to be hearing about at this meeting. And this explains why the payer's perspective of what we do is changing, and the metrics of our discussions will change. Go back to when I was a young oncologist. We focused basically on the activity of our drugs. Did the tumours respond when we treated them? But we've all lived through the era of evidence-based medicine, where we focus on helping patients live longer and live better, and ask the question, does this intervention make you live significantly longer and live better than the past generation control treatment? But we need to move you on now to something we call value-based medicine, where we focus on value. Now, the economists call it the cost per quality, the cost of buying one quality-adjusted life year. But for a stakeholder, a patient, remember, their value is their length of life, their quality of life. How much time in hospital, how much toxicity they would trade off for the benefits that our treatments will offer. And the question we ask now of any treatment advance you hear about at this meeting will be this: is this treatment worth doing compared with other things we could do with the same resource? Say for a patient, that might be time waiting in hospital. For a hospital, it might be, do you have enough oncologists, scanners, pharmacists, and access to the medicines? Put simply, it's like this: we have to learn to provide the most effective treatments in the most cost-effective way. And health economists don't come from a different planet. They look like us. Compared to physicians, we work in the same way. We're very realistic about life's problems. We rely on good data. The better the data, the better the decision. But we have to make choices in the face of uncertainty, just like physicians. And we know good decisions require us to look at the benefits and the risks. Now, there's a difference between us, and it's small, but it's important. Physicians are usually concerned with delivering the best health to the patient in your consulting room, whereas economists are worried about the big scale. They want to provide the most health to the most people with the resources that they have. You want to give the most health to a patient with the resources you have. So why are economists so focused on gastrointestinal cancers? Well, let me give you a clue. This looks at the diagnosis of cancer in Europe, and you'll see that we diagnosed 651,102 patients with GI malignancies in Europe last year, which is more than breast cancer, more than lung cancer, more than hematological malignancies, reproductive cancers, urological cancers. There is an enormous human cost to gastrointestinal cancer in Europe. And it's not just diagnosis, it's mortality, with more deaths than breast cancer and more deaths than lung cancer. It's not just a European problem. Let's cross over and see other countries as well. But we express that human cost in terms of morbidity and mortality, and it doesn't just affect the patient. A patient with cancer means a family with cancer. Time off from work, time for caring, time waiting in hospital. And these we call the indirect costs of what we do to patients. When you look at the economic perspective, it's always taken from the health system, something we call direct costs. What does it cost to give the medical care, to treat the complications of medical care? And we do worry about patient co-payments as well. And that tells you a different focus, doesn't it? So when you look, for example, at the National Health Service in England, where we have very good data, you'll see that the costs over a lifetime of cancer, from diagnosis through primary treatment, through salvage, through end-of-life care, is most expensive for colorectal cancer, more than breast, prostate, or lung cancer. It's true in America. 3 out of the top 5 costly cancers to treat are GI malignancies. Now, when we look at spending, we don't mind about high spending if it gives good results. But one thing that worries us is something we call variation. So if you look at the spending per case on colorectal cancer in Europe and the outcomes, you'll see something quite striking. The spend in Europe per patient can vary 20-fold between different health systems, without any evidence that that helps people live longer or live better. And conversely, for the same spend, European health systems can deliver outcomes that are 9% absolute difference. Imagine a trial shown to you today with a 9% absolute difference. That would be a must-have treatment for your health system. Well, the must-have takeaway from this story is that we must learn to work together in Europe to understand what drives differences. And the same regimens given either side of the border on the west coast of North America can cost twice as much to the south as it does to the north. Now, variation is a trigger word to a health economist. When there's variation in outcomes, treatment, or costs, we want to know why. And we generally think about it in these three groups. Is it that patients don't receive the right care? Is it that we could gain those benefits with fewer resources? Or is it that we're squandering resources on things that don't make people live longer and live better? So let's, for example, look at the pathway of colorectal cancer. We look at the journey of a patient because it's very informative. Well, if you start off and look, for example, at colorectal cancer, then the best thing you can do is diagnose it early. Stage 1 colorectal cancer has a cure rate 80% better than stage 4 5 years later. So almost any money you spend on screening and early diagnosis programs pays back. The cost of looking after a typical patient over that 10-year pathway is around 40 to 45,000 euros. And we can deliver better outcomes at 1/10 the cost if we can diagnose patients early. So I don't think the variation in colorectal outcomes comes from here. Well, now the second step is looking at primary treatment. What do we know about that? Well, we generally use multimodality treatment. We look at surgery, consider adjuvant chemotherapy or targeted therapies, and the role of radiation therapy as well. And here you can see how we've evolved to give the similar outcomes with less toxicity. The IDEA trial was very clear. You can give the same benefit with 3 months treatment if you select the right regimen, which is all generic, and oncologists who are health economists love generic medicines. They typically have an 85% price reduction within 2 years of launch. Just the Capox regimen alone saves significant money over the alternatives, and this is preferred by patients. So the value of primary treatment doesn't again seem to be the problem. In fact, this is what the economists love as a home run. We get the same outcomes that are preferred by patients for less cost. So where's the problem in colorectal cancer? Well, it's probably in the post-primary treatment, the lines and lines of therapy we can give to help our patients live longer and better with a burden of cancer. And just look at the targeted therapies we have available to us. And I'll just pick one of them, like bevacizumab, and give you an idea of how a health economist looks at this. The incremental cost effectiveness, the ICER, tells us how much the health system has to spend to help a patient get 1 more year of good quality life. And you'll see for the USA and for the UK, we're talking in terms of hundreds of thousands of dollars. For an American, it's 10 years of a family's wealth to get 1 year of good quality of life on that regimen. And that's probably where our troubles come. So Vogel in 2017 identified at least 5 regimens you could give as third or further lines with good evidence for benefit. But many more of those drugs don't have clinical benefits that are clear. They have surrogate benefits, progression-free survival, failure-free survival. In terms of quality of life, we know about toxicity, but not how well it leaves patients. So it's likely to be here that the problems arise. And yet our tumor boards, our groups of doctors that come together and help plan patients' treatments, tend to scrutinize the early treatments, not the later ones, where the greatest variation comes. And so today, this morning, you're going to hear a lot about delivering better data to drive those decisions. Now, if you're on your own in the clinic, what have you got? Well, you've got guidelines from our society, ESMO. And these, for a health economist, are quite useful because they've got lots of things we like. They give precedence to cure over deferral of death. They demand direct endpoints over surrogate endpoints. They prefer disease-free survival in curative disease as a more valid outcome than progression-free survival in a non-curative disease. But crucially, they fail because they don't take into account the value of that treatment. Well, what about America? Because the NCCN guidelines have a hint. They look at affordability. And they measure it between a low-cost, a medium, and a high-cost regimen. But you know, this fails as well because it's not about cost, it's about cost effectiveness. Let me tell you, economists never say cheap or expensive. We say a treatment is either cost effective or not cost effective. Because a high-cost treatment like chimeric antigen T-cell therapy could be highly cost effective because that high cost could deliver years of tumor control. So when I sit on the European Commission panel for affordable medicines, we're driven by this policy. Could we deliver the treatments we have with lower cost drugs? Because as the report says, every member state is struggling to provide innovative therapies. And we have to make use of every policy we have to deliver those drugs at lower cost. And if you read the document, page after page, it says we have to maximize our use of patent-expired drugs where brand competition can check prices. And that's generics and biosimilars, and that's through the whole report. Well, what opportunities do we have on this pathway? Well, of all those targeted precision therapies, one of them we have biosimilars for, ready for launch in 2020. Others, cetuximab, patent expired in 2016. We have no biosimilar yet launched in Europe or America, and none on the obvious horizon very soon. But it's very important that we maximize our chance to benefit that. There are many health systems in the world that can afford innovation because they make use of patent-expired last-generation innovation to drive wealth back to fund the next generation of drugs, which is why Joseph Taberno is going to tell you about the horizon scanning, getting ready for next year's biosimilars in GI oncology. Well, now, lastly, deciding the value of innovation is always a problem. But I told you only 3 countries decided that it was worth funding at least 7 out of 10, 40 out of the 55 recent innovative launches. And those 3 countries have something in common. All of them make decisions based on one metric. That's the cost per QALY, whether it's the American Institute for Clinical and Economic Review, the German IQWiG group, or Britain's NICE. It's all about the same thing. It's understanding whether the trials deliver an improvement in overall quality of life and overall length of life. And this is taking off. In Europe, every new innovative drug will go through at least 4 health technology assessments, and we welcome our colleagues from Japan on board. They launched their version of NICE called C2H 3 weeks ago. So, the conclusions to take away for this morning and then for the rest of the meeting. Cancer care is becoming unaffordable. The treatment advances you'll hear about at this meeting may not come through to your country in many years' time. And it matters very much for us in gastrointestinal cancer medicine, because the human cost of these diseases, in the financial cost, is significant. And within that, we see massive variation in the costs to care for our patients and the outcomes. Remember, economists don't like variation. And when we see that, we fall to pathway analysis. And when we look at that, we say, well, GI cancer has got some successes. We understand the success of early diagnosis and prevention. We understand the success of optimizing primary treatment. But we've identified the failures so far. It's the failure to pick out the best of our regimens for second line and beyond. And we've also found that our guideline tools are wanting, and when version 2 of these come out, they will have to evolve to reflect the value of the treatment we deliver. Thank you very much.